can. Good. Can you reach as far behind your back as possible? Good. And I might want to come around to the back and actually see how far she goes. So I'm going to have her turn around. I mean, you don't ask the person to turn, you can go around them. We can see how far. Good. Can you put your arm behind your head like this as far as you can go? I can start to see, does it look full enough? Okay. So I got to see that from the front. You also want to look from the back as well, because lift your arm up over your head. I want to see what that shoulder blade's doing. There's a scapulohumeral rhythm that I should see, okay? Generally speaking, what I want to see is the first 60 degrees. Her scapula should not be doing much movement at all, but as she gets into that second portion, I start to see the scapula starting to move with it until she gets to the last 60 degrees when all that motion's taken up, and then the glenohumeral joint should be predominating again, okay? That's what I expect to see. I expect to see the scapula smoothly, upwardly rotate and protract around. Some individuals can do that well going up, but coming down, they start coming down and you start to see this winning effect of the scapula. Those are the type of things you need to pick up on. Sometimes individuals, if they've got really bad problems, they immediately start like this. They're trying to raise, so the shoulder elevation is being a compensator. So I have them go through everything first so I have a baseline. And now I do the same thing for the right arm. So you can keep standing that way. Just put your arm all the way up over your head and bring it back down. Good. Can you do that a couple of times for me? And does any of that change your symptoms at all? Yes, no? Yes, it does. Okay, where? When do you feel it? What does it feel like? Those are the follow-up questions you need to ask, right? So go ahead. Arm up over your head. Back down. Might have her do it twice, just looking at it. She's okay. Put your arm up over your head again. There's a little levator scap tightness. Go ahead, put it down. It's minimal. Levator scap tightness, when the person lifts their arm over their head, her head will gravitate towards their arm. I had a professor in school, it was really bad. Hers is very slight at the very end. You barely see it come out a little bit. Yeah, if you see a person put an arm up over their head and their head is sideways, going, their head physically moves towards it, that's a sign of levator tightness. Abduction, so once again, put your arm out. So the abduct up over your head, same thing, go back down. Do that a couple times.
That's just what we preach.
Good. You actually see her head slide a little bit more with the abduction. Why is that, right? The levator's here, and what's the scapular doing? It's moving away this way. So, if it gets too far, the muscle needs to stretch. Okay? Muscles can limit motion. Now, she gets it, when she gets to the top, she's got to get this levator motion from somewhere, and if her arm's going to keep going, then what happens is the transverse processes need to get closer, because the length of the muscle is what it is. So her compensation is to move her head slightly over this way to get the transverse processes closer. So now her levator will give her the length she needs. Is that a problem if she lifts her hand up all day and her neck's giving her problems? Maybe. I don't know. All right, good. And then you take them through the rest of it, right? We want to see what's the motion, what does it look like, how does that change her symptoms? You have to get good at asking that, okay? Every time they move it, okay, any changes in your symptoms? Yes, okay, what? No, move on, all right? The second part is the passive range of motion. That's best done laying down. So I'm asking for follow this. And it's your, we're going to change on it for you, but you can lay down with your head that way. So I'm going to do the passive range of motion component. Passive range of motion has to be that, passive, okay? We talked a little bit in clinical skills how it's very hard to do something passively when I'm barely touching the person. This is hurting them, and I'm like, okay, just relax and let me move your arm up over your head, right? They're not going to feel comfortable just letting go of their limb because they don't know which way. This is very wobbly and loose. She's likely to not give me her arm, right? So scoot a little bit over to me. The way I always like doing shoulder, just relax. I take the elbow and bend it so it's resting on my forearm here. And I've got her elbow from underneath here. The second thing I always did passively, can we move these out of the way? Because I'm going to be going that way in about a second. I would take my other arm and I come underneath the humerus to support it, to support her humerus from underneath. And from the beginning, I kind of got her arm and said, just what's going to happen is I just saw what you did. Now I have to see what happens with your shoulder when I move it. So I need you to relax as much as possible. If you get any pain or discomfort along the way, just let me know. And we'll go from there, okay? So I start to passively bring her up. And I have to feel, I'm feeling with my hands, are they getting a muscle spasm? After a rotator cuff repair, as you go up, these muscles want to just catch. Well, you got to move gently and feel that happen. As soon as I feel that catch, I would stop. Okay, she got a little muscle spasm there around that range. Let me back off a little bit and see if I can go a little bit further. Sometimes you can. Sometimes it's just catching because, okay? So what you got to do is you got to slowly let the arm come all the way up and to end range. And once we're at end range, we talked about staying there 5 to 10 seconds. I'm loading up. This is the closed back position of the shoulder, right? I've completely maximally stretched out her capsule ligamentous structures, and I'm seeing how well do they do holding it there. Okay? If she's having like a mild bursitis going on, that initial going right to the top might not be enough to bring it out. But if I stay there a little while, now all of a sudden that bursitis starts getting irritable, and it's like, yeah, now that you're there, that's really uncomfortable. Oh, okay. So that's flexion. I have to do abduction. Abduction is not as, I used to like having a hand underneath. I bring their arm up over their head. And again, just stay there, 5 to 10 seconds. Okay, I can do internal and external rotation. I always did internal, external rotation. Okay, just relax your arm again. Once I have it, I can do internal rotation. Stay there a little while. How's that feel?
Fine.
Good. External rotation. Notice I'm watching my person's face. That can give away a lot. Good. If I wanted to do extension, I can ask her to just scoot a little bit more so your shoulder blades just off the edge, and I can just let her arm relax down, do extension. Okay, and then I can also do horizontal ab and adduction. So horizontal adduction, we're just going to come across. Abduction, we're going to go down.
Would we ask them about their change in symptoms here?
All the time. Yes, you have to be monitoring that, right? That's the whole point, correct? I'm just kind of showing you the flow of how you do one after the other. But the whole time, and that's what I said to her initially was, anytime you feel a problem, a change, let me know. And you should be asking throughout the process. Yes, that's a good point. All right, you can go a little bit more. So after the passive range of motion comes the resisted range of motion. I know the open pack position of the shoulder, 55 degrees of abduction, 30 degrees of horizontal adduction. But, I mean, just that loose pack position. What I'm going to do is, I just saw how you move the joint, and now I moved it for you. Now we're going to see how strong it is, okay? So what I want to do is I'm going to put your arm in a position. I just need you to hold it there for me as best you can, okay? So I'm going to hold your arm. First thing, can you just hold your arm right there for me? Some people with a bad root may not even be able to hold this position. Ah, that really hurts. Okay. She can't handle the weight of her arm resistance. Never mind me pushing on it, right? So that part's done. So I'm going to stay right there. Just kind of hold that arm up. Don't let me push it down. So I'm going to try flexion first. Kind of slowly ramp it up. See how she does. Did that change your symptoms at all? No? Okay. We're going this way now. She said yes.
I was agreeing with.
Hold, don't let me move you. Now I'm testing abduction. Same position. Good. We're going to arm wrestle each other. Don't let me win. So just kind of push against me. Internal rotation. I am externally rotating her. She's internally rotating. So that's internal. We're going to do the same thing but the opposite side. So hold here. Don't let me push you. Now I'm resisting. I'm pushing her into internal rotation, so she has to use her external rotators. That is something you have to get good at knowing. I'm pushing this way. That means they're using these muscles, okay? Don't let me push you up. Checking extensors. Good. I just want to put your arm here. Don't let me pull outward. So for horizontal AB adduction, I used to always change the position a little bit. Don't let me push you this way. And I'm going to that resistive range of motion chart. Strong and painless, no problem. Strong and painful, maybe a minor problem. Weak and painful, maybe a significant rupture problem. And then you have it was very weak, but it didn't cause any pain. Well, that might be another issue altogether. That could be a complete rupture and or a neurological problem if it's very weak and not painful. Once you tear the whole structure, you've ripped all the nerve endings, it can't really give you a lot of pain anymore. Very good way to find out, I don't know, how many ATs are in here? If you had an ACL tear on the field, how were they feeling after a little while? Or were they just cut it off and taken to the hospital?
They were, well,
every time we took them off, they were. I've only seen it once really.
Okay.
He felt fine initially, but then it started to like
Okay.
swell up, and that's when
Yeah,
he started to get
yeah.
pain.
Generally, if it's a partial rip or tear, it's super painful. They don't want to go back in the game. But if they did something where you think they might have really injured their knee, and they're telling you like 15 minutes later, I think I can go back in, it feels okay, and it's not so painful, they probably really tore something bad. And so those are the ones who say, no, you need to sit down. A partial tear, no one's going to let you put them back in, because that's per any little bit of movement, they're stretching and pulling on that ACL, and it's pain. But if you completely tear it, now it's not painful anymore. It's pain. That initial moment, it's painful, and I was like, oh, this isn't so bad. I think I'm okay. I think maybe I'll be all right. No. Same thing with rotator cuff tears. I mean, if you've significantly torn through a good portion of that, you may not get pain associated with that. Okay. Why is this important? I had a patient one time. This was funny. She was elderly, so actually, Janet, can you sit down here? I had her sitting in the chair. I decided, you know what? I'm not going to test her balance and make her stand up too long. She had a lot of, back problems and all that. But so she's in the chair. I decided to do my active range of motion testing in the chair. Diagnosis from the physician. The diagnosis was frozen shoulder. Okay. Can you lift your arm up over your head? She did. That's it. Doctor said, oh, I know what you got. You got frozen shoulder. Go see the therapist. Boom. That was it. That was the whole consult. Okay. So I'm asking her, can we do that? She's showing me. Can't. Abduction. Can't do it. It's like, yeah, it's just frozen down there. Okay. Let's do me a favor. Let's lay down on the table. So go ahead, Jana. Lay down on the table. This is what I do with my person. Lay down on the table. Okay. I saw what you could do with it, but now I'm going to move for you, and you let me know if there's any problems. And this is what I proceed to do. In the meantime, her eyes are like, I didn't know my arm could go that high. And I was like, yeah. She looks at me and says, that's not a frozen shoulder. And I'm like, probably not. But I'm a PT. I'm not allowed to tell you, you don't have that.
Yeah, because she.
And I'm certainly not allowed to tell her. What do you think she had after those 2 points? She couldn't do it herself, but I could do it for her. What does that tell you? Right. Her muscles have the incapacity to lift her arm up through the range that she has. Her physiological end range is here. Her anatomical end range was way up here at this moment in time. Right? So what am I immediately thinking? What diagnosis? Muscle, tendon, shoulder. What do you guys think? Supraspinatus, or just more general A? Rotator cuff tear. She's got a rotator cuff tear, plain as day. Plain as day. The physician missed it because he did one part of the 3 steps he should have done. And if he would have taken 30 seconds and tried to passively lift the arm over the person's head, he would not have said that was true. But in his infinite wisdom, he had seen this so many times. If you can only move your arm this high, that's a frozen shoulder. Go see therapy. You got a frozen shoulder. So I go through the rest of my exam like, listen, obviously your shoulder's capable of moving a lot more than you can move it yourself. So I think we're going to have to work on your muscles there. And I'm going to talk to your doctor and let him know that's what we found. And sure enough, I'm not a and we ended up keep treating her because they're going to she was elderly. I mean, they probably weren't wanting to do surgery on her. See what she can get out of therapy for it. And Lord knows, I can't remember what happened with her the rest of the way, but that was just really eye-opening to me. Like, if you don't do all 3, you can really miss the big picture, right? You have to do all 3.
You may have said this, but so you're not allowed to give a diagnosis, but can you say, I think, based on my findings, you have a rotator cuff tear?
I mean, she knew right away. She's like, that's not a rotator cuff. The patient knew that wasn't that was a frozen shoulder. She knew it wasn't a frozen shoulder. I was like, well, you have that. There's some tightness there. You try not to. That's where you got to play politician.